and other pediatric orthopedic care. If you do have questions during the presentation, please feel free to post them in the chat box as we go through. Following the presentation, as I said, we will open it up for questions and answers. So let's get started. The first topic, as I said, is just returning to youth sports after COVID-19. Next. Just for some background, there are estimated to be somewhere between 35 and 45 million youth that are between the ages of 6 and 18 that do participate in some form of athletics in the United States. And the COVID-19 pandemic affected many aspects of the lives of children and families, including youth sport activity. This year, we saw sports stop, and then we saw some sports restart. Then we saw pauses. Then we saw shutdowns. We saw quarantines. We saw slow rollouts. We saw pretty much every form of different shape and size that sports could take. And it's been a confusing one for all of us. We know from some studies that have been done over the last year that the amount of hours that kids spent playing sports declined across their 50%. And as physicians, we certainly understand the benefits of returning to sports and physical activity, and we want to encourage all of our patients to re-engage in sports. Not only is there physical benefits, there's also psychologic and health benefits for children and adolescents as well. Mentally, youth may experience benefits from the increased socialization with friends, coaches, and a return to a more structured routine. But obviously we want them to do that in as safe a manner as possible. So we're going to discuss today for families how to determine if your child does have an injury or pain, when that might need a doctor's attention. We're going to discuss some common pediatric orthopedic injuries in youth sports, first in the upper extremity as well as the lower extremity. And then finally, we will give you a few tips for returning to athletics. So our first speaker is Dr. Stephen Adelson. Dr. Adelson specializes in general pediatric orthopedic care, pediatric trauma, spinal deformity, and lower limb deformity.
All right, great to be here. So I'm going to take a couple minutes just to get things started with the first part of the talk on when does an injury or pain need a doctor's attention. A little bit about myself. Just to let everybody know, I'm also in the thick of it, along with you. So these are my kids. I have a 10-year-old and an 8-year-old who play soccer, mainly soccer and swim. And it was an interesting time of mask wearing and pauses and you know, getting sports back in action. So for the purposes of this talk, I'm going to kind of break it up into injury, and then a couple words on pain separately. I'm not going to get into too much detail because I'm going to save that for Dr. Bellick and Dr. Mcpartland, who are going to touch on a couple particulars just in terms of diagnoses. So if we start with injury as a good starting point, say you're out of practice or a game and it's an actual injury. If there is no obvious swelling or deformity, a great starting point. I'm sure many have heard of the RICE protocol. So RICE standing for rest, ice, and that can be for multiple times. You could do for say 15, 20 minutes and spread it out, maybe every hour or so. Compression, ACE bandage always works nicely. You want to make sure you don't wrap it too tight. And then of course elevation. So when we say elevation, typically we're trying to get the either toes or fingers, depending on where the injury is, above the level of the heart. So sometimes it's a little harder than you think if you think about certain parts of the body. So a lot of times you got to lay yourself down and really get your foot kind of up in the air And then I would definitely add on to the RICE protocol there an anti-inflammatory, of course, if you don't have any allergies to medications or problems with medications. I won't go over dosing or anything just because I think in terms of kids under, a certain size, say age 12 to 14, who would be old enough to have the adult dose, it's pretty clearly marked on the bottle. Just make sure you're actually dosing it correctly. I think there's a lot of folks who probably are underdosing as well. And it's not a bad idea for that first 24 to 48 hours to actually make it routine. So every 6 hours, as a routine for at least say the first 24 hours, and then in general you can reevaluate. So the next the next morning is unwrap and reevaluate and see what's going on. Now that was a starting point if there was nothing obviously deformed or swollen, but some important red flags would be significant swelling, right, or obvious deformity, and a laceration either itself or at the site of an injury, especially. Two great examples, probably just to proceed right to immediate care. And then some others, say you do decide to go home and do the RICE protocol, and a few hours later or that night, you notice you're doing everything correctly, you're elevating it, you're icing it, you have it wrapped, you're using the pain, Motrin or pain medication, anti-inflammatory, and they're just absolutely inconsolable, even actually doing all those things. That's probably a sign it's worth kind of more of an emergency evaluation to check things out. And then finally, if you've done kind of your 24 to 48 hours and gone home and done your job and it's just still not better or not improving, when you reevaluate that next day, or say for lower extremities, really just completely unable to bear weight even after the 24 hours. That's probably a good sign that it's time to take it to the next level. So I just want to take a minute to talk about where. I think that's a common question we get. Do I go to an urgent care? Do I go right to the emergency room? I kind of like to look at, the urgent care is a great way, I think, just to see if you're unsure if the injury is severe or not. So it kind of gives you a quicker answer. Most of them are equipped to do x-rays, where they can just give you kind of a simple answer. Okay, is this really serious, or is it something that can be seen over the next, say, 5 to 7 days? And at the same time, they can provide some temporary treatment, say with splinting, so that you're more comfortable as you schedule an appointment for further follow-up. In terms of the emergency room, I will make one note. I'm sure we're allowed to make a plug for our hospital, which has a children's hospital, is that at children's hospitals, like at RWJBarnabas and Bristol-Myers Squibb Children's Hospital, we have the capability for injuries. These are the bad injuries that right on the field don't look right, and you're proceeding to the emergency room. We have the capability to do a lot of our care in the emergency room. So we're actually capable of doing conscious sedation and setting bones and putting on temporary casts or splints. You can actually go home the same night or evening in a lot of cases. Of course, obviously, if there's any question, go to your local ER. Robert Wood Johnson also has a great transfer service. So we do take care of a lot of kids who go to other hospitals and then need further care at our children's hospital. In terms of pediatrician and specialists, of course, if you have a good relationship with your pediatrician, I know some are comfortable with seeing some injuries in the office and can provide kind of the same service with seeing if the injury is severe or not. But I think most end up coming even after they seek temporary treatment and then scheduling a follow-up. In general, if you receive treatment, it's perfectly safe, I think, to wait, and come see us within that. 3 to 5 days would be great. And then a word on pain, and then I'll pass it along. So separating out pain, this is a little bit different from an injury. This is more when you have a child who's complaining of pain, say during or after sports. Okay, when do I need to actually pick up the phone and bring this to the next level? So a couple things to look out for. One would be physical changes, meaning say swelling, bruising, especially after sports. If it becomes activity limiting, meaning it actually gets to the point where they're unable to continue to participate in sports. If it doesn't respond to your RICE treatment, if it's not generally better by the next day, or if it lingers, they're waking up the following day still with symptoms and it's still bothering them, and it just keeps getting worse and worse and worse and worse over the ensuing days. And then also if you decide to rest it, which I think is a great idea, my wife and kids make fun of me because I tell them they're not allowed to complain of pain until they've rested it for 2 weeks. And if you've rested it at home for a week or two, and then you try to return to your activity, and then the pain comes back, I think it's a great time. So overall, we're trying to kind of look for, there's the good, the bad, and the ugly. And when I say the good, all I'm saying is that hurt doesn't equal harm, and you're not doing any damage or anything to yourself, like sprains, strains, contusions, and the different types of growing pains. We're always on the lookout for kind of the bad. These are the things that can cause, future issues if you don't kind of get them checked out right away. But my point with the slide, again, not going into detail because Dr. Bellick and Dr. Mcpartland will do that, is the point is using these guidelines will get you to us to make that timely diagnosis. So thanks for listening to me. I think we're going to pass it, I guess, back to Dr. Harnley. She'll pass it on from there.
Yeah, thank you, Dr. Adelson. So our next speaker is Dr. Deidre Bellick. Dr. Bellick specializes in pediatric hand surgery, reconstructive upper extremity issues following trauma, upper limb deformity correction, congenital or birth defects of the upper limb, cerebral palsy in the upper limb, and burn contracture correction. So she'll speak to us on the next topic, common upper extremity pediatric sports injuries.
Thank you guys for having me here. As Dr. Harnley said, I mostly take care of hand and upper extremity, so basically shoulder down, although I do a little bit of general pediatric trauma work too. My talk is pretty general and basic because while there are common injuries in sports, you can have almost any injury in any part of the body. And if we went through every single injury, we'd probably be here for a couple of days. But I try to touch on things in general and then let you know when you need to come and see us and in what time frame. So next. So the first thing to kind of think about is what type of injury does my child have? And Dr. Adelson's talk touched on this a little bit at the end. Do we have an acute traumatic injury, meaning that it happened relatively recently and a result of a specific event? Usually we're not able to play through those types of injuries, but not all the time. Or is it a chronic overuse type of injury? That means there's not really a specific event that we can relate it to. Maybe it starts every time we play, but no specific injury in general. It may have began a while ago. It usually starts off very mild and will get worse with time. And your child may or may not have been able to play through that type of event. Next. So when we think of traumatic injuries, again, this is from a specific identifiable cause. What would fall into this category would be things like fractures or breaks, sprains, tendon tears, ligament tears, lacerations, muscle strains, and contusions. All of these, again, happen from a single identifiable event that you can say, yes, he was on the field and collided with another player, and since that time, my wrist had turned. Next. So when we break it down a little bit more, again, I don't speak of any general, I speak a little more general. We look at tendon tears and muscle strains, which are very, very common in youth athletics. So a tendon and a muscle is what causes our bones to move. Tendons attach the muscle to the bone. This can result from many different types of patterns of injury, but it also causes localized pain and swelling in the area of the injury. And usually kids are able to move with this type of injury and still are able to bear weight if it's in the lower extremity. Next. Contusions are from an impact with another player or an object during the sport. Again, causes localized pain, swelling, and bruising in the area that's hit. Kids are still often able to move, and they do have mild pain. And the level of the bruise can differ depending on how hard the contact was. So it can be as superficial as just the skin, or it can be deeper and have what we actually call bone bruises, which can be a little more painful and take a while to heal. Next. Lacerations, this is pretty basic. It's basically a cut. They can be very superficial or they can be deep. If you're not sure if it's deep and requires stitches, it's best to have it evaluated and cleaned and sutured in an emergency department. Some urgent care places can do this, some can. It really depends on their capability and the comfort of the doctor that tends to be on. Again, shameless plug for our hospital. Robert Wood Johnson University Hospital does a great job taking care of this in children. Next. And then fracture is probably one of the most common injuries that we see. It results from either a fall or an impact with another athlete or the ball. It can cause, again, swelling, deformity, and bruising. And it's often difficult to move the affected area. If it's in the lower extremity, it's often difficult to bear weight on that. Fractures in the upper extremity are the most common fractures in all children. So number 1 being finger fractures, number 2 being wrist fractures, and number 3 being elbow fractures. So it's something we pretty commonly see here. The big question is whether or not you need to come and see us. And my general rule is if something doesn't look straight, you should come and see us sooner rather than later. Otherwise, we can head to the urgent care or the ER just to get an initial evaluation, or sometimes wait till the next day when there's an open appointment. Next. And just as a specific type of fracture, one of the most common things we see here is a wrist fracture, which is usually from a fall on the outstretched hand. There'll usually be swelling around the wrist. Usually your child is unable to move it again, and they usually will have point tenderness in the area that it is. If the pain does not resolve within a day or two, you definitely want to come and see us. Usually time frame for seeing an orthopedic doctor after a fracture should be within the first week of injury. It's best to seek some type of care immediately for casting or splinting, whether that's at your urgent care or whether you come and see us initially. Some of that really depends on the timing of the injury. If you're injured in the middle of the night and it's a Saturday night, our general office isn't open, so I usually recommend that you head to either an urgent care center or Robert Wood Johnson for that. Next. And then moving into chronic overuse injuries, this is from repetitive stress, another common thing we see in our athletes. I actually think I see this a little more commonly sometimes than fractures. This falls into the realm of tendonitis, stress reactions, or fractures, which we'll talk a little bit about what those are, and then muscle weakness and imbalance. The stress fractures and stress reactions are really common in our overhead athletes, like our baseball players from throwing repetitively. And also we see this in our wrists and gymnasts a lot. Next. So tendonitis, again, from repetitive overuse. We also have been seeing it a lot more recently since COVID due to rapid reintegration into sports. A lot of youth athletics, as they ramp back up, have kind of gone full steam ahead, and kids went from completely resting to jumping right back into sports without really much warm up, and they're a little bit deconditioned. So I do think I've seen a little more tendonitis recently due to this than I have in the past in kids. The treatment is rest. Usually we recommend at least a week or 2 of rest from activities that are making it worse. And then when we restart and reintegrate into sports, the trick is to go slowly and ease back into it, not go from 0 to 100%. If the pain doesn't resolve within a couple of weeks, it's best to make an appointment to see us. Next. Stress fracture or stress reaction. This is from repetitive overuse also. The pain usually worsens with a specific activity. It usually occurs in children from weak points in the child's bones, such as growth plates. And kids are at highest risk during their periods of rapid growth. Again, the treatment is rest and then sometimes physical therapy to fix mechanical issues. The problem with this type of reaction is that because it's an injury to the growth plate, if you ignore it, it can affect the growth plate and affect long-term growth. And it does usually take more rest than your tendonitis. So it usually can take 6 weeks to 3 months, depending on the type of stress reaction we have, to get this better. Next. And then as an example of this, I put in Little Leaguer's elbow, which is from chronic throwing and stress on the inside portion of the elbow. This happens because, again, kids have a growth plate right there, and all of the muscles and ligaments that attach on the inside of our elbow attach at the same space. This is usually the biggest problem in our pitchers, but it can be a problem in any of our throwing athletes. One of the biggest risk factors for it is playing multiple positions while being a pitcher. So being a pitcher and a catcher is one of the worst things that your child can do because each position is still throwing the ball the same amount of time. So I'll usually tell most of my pitchers, pick one or the other, whichever position they really like personally better, they should develop that rather than switch from spot to spot. You shouldn't pitch a couple innings and then go in as a catcher. The treatment for this is rest and then therapy afterwards to fix any mechanical issues. But the best treatment we have for this is actually prevention. Next. Oh, sorry, I kind of talked about this, so I guess we can skip this slide next. So for prevention, really, it's all about the number of pitches that we're throwing and how many times a week we're throwing. And it changes based on the age because of that growth plate that we talked about. This chart that I have in the slide is not my chart. It's from Major League Baseball Pitch Smart, which is a website that you can access just by Googling it. And it's really interactive. You can actually click on your child's age and it will tell you how many pitches they're allowed to throw and how, if they throw a certain amount of pitches, how many days of rest they should have in between. And as you can see, the numbers change via age. And this is important to keep track of because some people will come in and say, oh, my kid doesn't pitch that many pitches, but they're thinking of only games or one game at a time. Every game is a pitching event. So if you play in a tournament and there's 4 games and your kid pitches in every game, each one of those games, the total amount have to add up, and then you have to rest for the appropriate amount of time. So the big issue I'll see is a weekend tournament where one kid pitches 4 innings one day and maybe throws 50 pitches and then doesn't rest and throws 50 pitches the next day. And again, this is at our highest risk right as kids are transitioning into a higher level of play because it's our growth spurt years, which tends to be when they're going from kind of that majors Babe Ruth into high school type of age range. And that's when they also tend to start throwing a little bit harder. The mound gets a little bit further away. And sometimes they start to try and throw a little more pitches. So the other thing the Major League Pitch Smart page goes to is what pitches are safe to throw at what age, the curveball being the biggest problem factor for the types of pitches being thrown. Next. And again, the treatment for this is rest at first, but once we do rest, the important thing to realize is that this is a whole body problem. So when we do rehab afterwards, often kids have a problem with their throwing mechanics, and that problem with throwing mechanics can put increased stress on the elbow. Since the elbow is already at increased stress from just throwing, we want to make sure that we maximize the way we throw to avoid that overstress. So I actually think that the rehab and therapy is one of the important preventative measures for making sure this doesn't come back, especially as kids are going through those growth spurts. Even if they had perfect mechanics at one point, as they start to grow, their muscles get stretched, they get a little imbalanced. And again, they start to throw harder and start to turn their body and almost whip their arm around, and you get this slingshot effect. So when we send them to therapy, one of the most common remarks I get from parents is, oh, you know, they were working on their abs or their legs a lot. And the reason is because it's all one big chain. Everything's connected. So you have to make sure you rehab everything from the bottom up to make sure that we're throwing and not using our arm as the major fulcrum for throwing or the major slingshot. And we're getting power from our more powerful muscles, which would be our legs. So that's just a little bit on a common injury that I deal with. Dr. Mcpartland is going to talk about lower extremity stuff next, so I guess I'll pass it off to Dr. Harnley again.
That was great. Thank you, Dr. Bellick. So our next speaker is Dr. Thomas Mcpartland. Dr. Mcpartland specializes in general pediatric orthopedic care, spinal deformities, has a special interest in hip and pelvic deformity, and correction of limb deformity. So he's going to give our next topic of lower extremity injuries.
Thank you, Dr. Harnley, and hello to everybody, and thanks for joining in today. Really apropos topic, partners that kids coming sports with up sports and seeing a high rate of injury from overuse. And I'm going to focus a little bit on acute injuries and overuse injuries of the lower extremities, and I want to try to dispel some myths and things, misconceptions that might be out there about, you know, how we evaluate these, how much we worry about different problems, and we'll talk a little bit about prevention too. So I think you're advancing the slides. Thank you, Dr. Harnley. So biomechanics are a very complicated thing, and I loved physics in high school. Many of you may cringe when you hear that word. But it's really interesting to think about how the human body moves and how you generate force. If you look at this diagram in front of you now and look at what happens to the peak power when you are actually jumping off the ground and landing in a squat. If you look at the peak is actually greater when you land and go into that squat. And the forces are very different at the hip and at the knee and at the ankle. If you can imagine at that deep squat, when you land, the force behind your kneecap is 10 times your body weight. And that's a compressive force around a corner. And so that's why the kneecap is a very common place where we see our teenage athletes have pain. And I think we'd all agree we're seeing more of that now than before because they are a little bit out of condition, because we rely really heavily on the shared load on the muscles to take up that force. So we're weak in our glutes and our buttock muscles. When we land, we may put more force in our quads and more compressive forces in our knees. You can also see how shoes fit into this too. The right kind of shoes can really help to buttress this and support us. And we know from scientific studies, there's different ways that we can land. There's ways to learn to be a better jumper. And that's what a lot of performance improvement programs kind of go into. But I just wanted to present this to get your gears turning and thinking about, why we run into some of these problems, especially in our growing athletes. Go ahead, Dr. Harmon. I don't want to reiterate too much. Dr. Bellick covered this pretty nicely. Sprains or ligament injuries, strains or injuries to the muscle or the tendon unit, fractures are obviously bony injuries, and the dislocations are dissociations of the joint. In the lower extremity, fortunately, we don't see a huge number of these. The kneecap, though, can dislocate, and many of you may know somebody, and that's a really disconcerting injury, and you can really, sometimes help someone out by just straightening their knee out and letting it slide right back into place, kind of like this kid sliding into home right here, okay? Heather, go ahead to the next one there. When we talk about overuse injuries, the types that we talk about are tendonitis, which Dr. Bellick spent some time on. I want to spend a little bit of time talking about something called apophysitis, which is pain related to the growing areas in the legs. It doesn't lead to growth arrest or problems, and it's treated pretty simply, but there are a lot of misconceptions out there, and I want to touch briefly on stress fractures as well. So when we say sprain, we're talking about an injury to a ligament, all right? And I'm going to show you a slide shortly that shows that in the teenage population, the burden of athletic injury falls really heavily on the knee and on the ankle. And the ankle, in the US, there's over 25,000 ankle sprains a day, and that's for all age groups, okay? But it is probably the most common reason for an athlete of any age to miss time from play. The ligaments that you see in the picture here, okay, one is an anatomic section and one is more of a diagram, are ligaments that are tugged and pulled when your ankle turns sideways, as you see in the mechanism here. And this can happen very simply from an uneven playing surface, from wearing poor shoe wear, from landing on a basketball or stepping on a soccer ball wrong. And if any of you have experienced an ankle sprain, it can really be debilitating. And we grade the level of this by the severity. And usually that can predict for us how quickly they'll recover. Fortunately, most of these recover uneventfully, and they do exactly what we do what Dr. Adelson said. We use rest, ice, compression, elevation. Sometimes the rest includes going on crutches for a while. We use a lot of boots and braces in the office. But most ankle sprains will recover uneventfully and not lead to any long-term problems. But you all probably know someone who has a chronic ankle instability issue, and when those get more complicated, we have ways to handle them. But as we're coming back from the pandemic and our kids are getting active again, I wouldn't be surprised if we see a lot of ankle sprains. And I think having cool heads about it and understanding that it's going to hurt and we give it a few days, and if we're not getting better, then we definitely want to get it evaluated, okay? What happens if you have an ankle sprain and you miss a fracture, and waiting a couple days on it? Nothing bad is going to happen. So it's okay for you to use your parental judgment to make those decisions. But if you're unsure, just consult with a physician, whether it's urgent care, at the hospital, your pediatrician, or one of us. When you deal with sprains, and then this next topic is strains, we're really talking about inflammation, which is a body's chemical process. And the reason we get pain with it is so our body tells us something's wrong. That feedback's there for a reason. And quite honestly, we use that to judge when someone's ready to go back. When I ask my teenage patients, hey, do you think you can play? I'm really asking them, hey, do you think you can play? Because their body's feedback is the most useful mechanism to tell us when they're okay. But sometimes you can have injuries that are giving you information that is, chronic and not so useful. So strains like jumper's knee here, someone playing basketball, especially on a hardwood floor where you get quick stop and start, you can get a strain in the tendon, okay? And that can be inflamed and irritated, but it doesn't mean you can't play. It's something you can play through. And generally, if you rest and stop playing, it'll get better. But sometimes we don't feel like we can do that. What I want you to take away today is an idea of maybe when you ought to step away, okay? This does respond to rest and ice and stretching. The muscles that are attached to your patella, your kneecap, can get very tight, especially if you've gone through a growth spurt or haven't played sports in a while, and it can become a problem for you. And stretching those muscles the right way and strengthening them the right way can be helpful. And it's important. I coach some youth sports in football and in baseball. And, I noticed that a lot of the other coaches are not really thinking a lot about, their stretching. I know playing sports as a child, we spent 15 minutes stretching. And I think there's unfortunately less emphasis on that. And if that's the case, draw attention to it with your teams or have your kids stretch at home and have them stretch every day, because that can really help avoid injuries. And then the other type of injury we talk about is fracture. I don't want to dwell on this too much, but if you look at the picture of the ankle on the right there, that bruise doesn't tell me if that ankle's fractured or not. That kid could be walking on that ankle. Now I see that there's an OR drape there, so I have a suspicion that child is having surgery right now. But bad bruises don't necessarily mean bad pathology. You could have a bruise that looks like that and you can walk on it. Really, if your child can't bear weight, that's the way to tell if this is a fairly serious injury in the lower extremity or not. If they're walking it off and getting better every day for a couple of days after, they're going to be fine, and just give them time, okay? But if a child has a fracture, okay, they generally will not be able to bear weight, but a bad sprain can be the same, and maybe you do need the help of a physician to help you differentiate that, okay? I'm not going to spend time on dislocations. If you see a joint that's out of position, you should seek medical care. I want to talk about overuse injuries, and this is a really interesting slide I found in the American Journal of Family Physicians this was 2021 actually, and it actually looked, the chart shows you how many years you've been involved with the sport and the rate of overuse injuries at different time periods for how long you've been playing. So as you become a seasoned veteran in your sport, the rate of injuries really drops off after 1 to 5 years. What's interesting is that right now, all of our kids may be back to that 1 to 5 years because they have not been conditioning and keeping themselves in shape, and their bodies have been growing. The other risk factors for overuse injuries, as Dr. Bellick alluded to, is being on multiple teams with decreased rest. And certainly I would echo that pitching and catching are one of the biggest problems. But we see a lot of early sports specialization that we didn't have when we were kids, where we're doing the same sport all year long. And we may be playing on an AstroTurf surface, which could have more stress on the legs. And we may be doing a lot of running, Naismith designed basketball as a bridge between, football and baseball season, because it was a different type of conditioning in the off season. And I think he was onto something there, because the idea was that we weren't trying to do too much in the same vein. It's good for the body to have rest. It's good to have time off between. And I think some of our sports that are highest risk for this are things like soccer with year-round club teams, gymnastics and dance, which are definitely sports, because they're going year round and they're going just as hard as our, traditional sport athletes are. Cheer as well can be a problem. And you just have to look and make sure that if your kids are starting to complain consistently and they haven't had a break in a while, you got to look at that chronic schedule. And I think we're hitting reset a little bit. A big topic that fits in here is this changing strength to weight ratio. As your child grows, the strength of the muscles does not remain proportional to body size. And this is particularly true between the ages of 10 and 14. If you probably remember feeling a little awkward at that age and a little off balance where you were a little more seasoned even a couple of years before that, because your body's growing so rapidly and your muscles don't get big because of that. And we're not going to put our kids on weight training programs and things at that young age, but we can put them on body weight programs and have them, work on lunges and squats and burpees and core exercises, because what we have to realize, can you go to the next slide, Dr. Harnley, is that our body is linked in a kinetic chain, okay? Every part of our body is working when we're doing activity like running. Think about running right now. Your shoulders pump, your arms pump. There's a rotation in your waist. There's a rotation in your pelvis. When you run up a hill, you run down a hill, you have different muscle forces on there. And the muscles have to work antagonistically. They have to work together and they have to work against one another to balance those forces. We used to joke about beach muscles in high school. Everyone just went to the weight room and wanted to do bench press and biceps. So they had big beach muscles. But you know what? That can cause some serious problems because you're not balanced in other areas. You can get stiff and tight. And so the real key is to understand that when you train your lower extremities, you have to train your upper extremities, and you have to train your core, because your core, your abdominal muscles, your glutes, they are the link between the upper and lower body, and they dissipate a huge amount of force when you're active. They also allow you to be much more athletic, because the core lets your upper body do different things than your lower body. If you're strong, if you're weak, you can't dissociate those. And they often say that's what differentiates elite athletes. Calvin Johnson was a wide receiver for the Detroit Lions. He was 6'10", but he could hold his body horizontal on a flagpole. That's an exercise literally called a flagpole. And he could lay himself out and catch a ball in the end zone, 2 inches off the ground, even though he was 6'10", because he had that body control. I'm not asking our kids to have that, but recognize that the reason that we all did calisthenics in gym growing up, our kids do a lot less of them than we did, is because people recognize those biomechanical linkages early on. And don't forget that proper equipment is really important too. You get what you pay for in shoes, and if your kids do a lot of running, they really need to have good shoes to run in. They're not wearing as supportive shoes. Sneakers are not hip in school anymore like they were when we were kids, and the basketball shoes that kids like aren't even the best shoes out there. Running shoes, cross-training shoes probably work the best, and if you come to see one of us, we'll probably wind up talking a lot about shoes if your legs are bothering you. The next slide, please. So I'm going to touch briefly on tendonitis. This is an overload injury. It doesn't go on to cause problems with rupture. Achilles tendonitis is pretty common in dancers and in some runners. Sometimes it's hard to get through it. It's safe to run through that pain, but if you need to hear us tell you that, that's perfectly okay. But they're not going to get better until they rest and stretch. And many times modifying shoes, strengthening antagonistic muscles, even looking at their running style can help. And then changing the terrain. If you have a cross-country runner who's running a lot of hills, taking them off the hills for a while can help. If your kid runs on a track and their right leg hurts, have them run the other way on the track, because then you're putting not as much stress on the right leg, which is the outer leg, and get some more compressive centripetal forces. Physical therapy can sometimes really help. There's some specific training programs there. Apophysitis I wanted to touch on really briefly. So you may have heard of Osgood-Schlatter's disease or Sever's apophysitis. I put a diagram here of some different sites where people get pain in the body. And many of us had Osgood-Schlatter's growing up. I know I did. My daughter's suffering from Sever's apophysitis, which is inflammation of the heel. This is where the muscles attach to the growing part of the bone. This doesn't make your bones longer. It makes your bones bigger, so that when you're 15, the place where your quadricep attaches to your leg to make it move is not as big as it was when you were 5. It has to grow with you, but it can get inflamed. And fortunately, these don't rupture or fracture, and you can treat them with rest and ice and stretching. There's a lot of misinformation, if you will, out there about Osgood-Schlatter's and Sever's apophysitis that you have to get out of sports. You can participate with these. It's just not going to get better until you actually rest it, or it's going to take a lot longer to get better. And it's important to understand that it's safe, but I would do that under the advice of a physician if you have concerns. Stress fractures are what we're looking out for, okay? And stress fractures are not going to be like your Sever's apophysitis, because they're going to occur in areas where it actually hurts on a bone, okay? Not on a growth plate, or not on a tendon, or not at a ligament, and ligaments are around your joints. Stress fractures are very common in runners in the fibula, in the tibia, occasionally in the femoral neck, and these are sometimes hard to differentiate from shin splints. If you have more than 3 weeks of pain, and it really bothers you after you've run for a while, and at about the same distance that you ran every time, it hurts in exactly the same place, and when you rest, you're okay, you could have a stress fracture, and you have to be careful. And if it's starting to become painful, they're usually pain-free at rest, but it really takes the activity to hurt. So if you hurt on a bone, and it hurts to touch on a bone, and you have been having symptoms for a while, it's probably worth investigating this. And it takes a long time to recover from these injuries. Sometimes you have to rest for several months, and then you have to look at your biomechanics and make all the muscle groups stronger to dissipate stress. And again, looking at the shoes and sometimes orthotics. So how do you prepare yourself to get back into these activities? Well, I think that if your kids are not on the field yet, but they want to start a sport, you want to try to anticipate what the demand of the sport is going to be and prepare. You want to have them gradually increase their level of activity as you're getting up and getting yourself ready. You want to have them start to stretch and work on flexibility and mobility. They should really be working on multiple muscle groups, not just particular areas that you think are relevant to the sport. As we've discussed in several instances earlier, the biomechanics are complicated, and you really need core strength and lower extremity strength to protect yourself. It's also really important as it gets hot over the summer to realize our kids may not be conditioned to recognize the signs of heat problems and to stay well hydrated. It's important that they are eating well, okay? We need balanced nutrition. We need to make sure that we are getting good protein calories in our body. We need to help build strong bones and muscles. And having a balanced diet is really important. And you can't overestimate the value of sleep in all of this, especially as we get into high school. Poor sleep affects our judgment. Poor sleep affects our ability to recover. And it's something that we sometimes don't prioritize, but we probably need to prioritize it more as we're getting ourselves ready. I'm interested to hear what everyone's concerns are about getting their kids back on the field, but I think this is one way you can really start to think about getting yourself ready. that my last slide, Dr. Harnley?
Yeah, that was terrific. Thank you, Dr. Mcpartland. I just wanted to conclude the presentation with some tips for returning to sports after this very strange year. We know everybody is coming from different places and different activities and may have more specific questions, which again, we were happy to address at the end of the talk. So these tips are a little more generalized, but I think they are applicable to everybody. Number one, first and foremost, coming back in 2021 after 2020 is a lot like coming back after an injury. And it's best to start that with a clean slate. That means no performance expectations about your child. Your child should not have expectations about their own performance. If they were able to do X, Y, or Z a year ago, that doesn't necessarily mean they're going to pick up right where they left off. So just take that into consideration. This has been a big gap for a lot of kids, and let's give them some space to readjust without comparing themselves to what they used to be able to do or to what other people who did different things this year were able to do as well. So just keep that in mind. So in that same line, number two, just resetting your own baseline, give them time, give them space. Most American adults have gained 28 pounds in this last year. So let's not have unrealistic expectations for our kids. If they've been in their bedroom attending school remotely for a year, they may need some time and space to kind of adjust to being outside and being active again. So let's all give ourselves some room for grace. Number three, I think it's important for parents to be open-minded. Up to 50 to 60% of kids often quit sports during their middle school years, and studies have shown that this pandemic may have accelerated that rate of kids no longer expressing the same interest in sports that they used to. We just would encourage kids to be outside and to be active. Try something new, sign up for a rock climbing class, consider skateboarding. If they used to be on 4 different travel teams for baseball but aren't excited about it anymore, maybe just try something that's a local rec league that's more fun. Try a new coach, just approach it from a different angle. Don't be afraid to explore and expand horizons. I think we all know that anxiety is real, whether it is performance anxiety, social anxiety, still fear of COVID. All kids at all ages are reporting higher levels of anxiety this year. There is no magic potion. We all have to make space for it, acknowledge it, talk about it, and let's let them set this pace. I think it's important for all parents to be patient with restrictions. We have seen that those restrictions vary state by state, county by county, venue by venue, month by month, week by week. And we just have to remember that everyone involved is working hard to keep kids and communities safe. So continuing to give everyone making these decisions, public health officials, venue owners, coaches, other parents, give them the benefit of the doubt. Dr. Mcpartland touched on this, but plan ahead for preseason preparation. And this is probably the most important part of this talk. Adjust the amount of time spent in preseason training to the level of athletics that the kid is planning to be participating in. For somebody who's in 8th grade and wants to try out for 9th grade cross country, they should not begin running in September. They should begin running now in May and beginning a graduated program of plyometrics, strengthening, conditioning, neuromuscular training, doing that well in advance and really turning the dial. I like to recommend kind of the 10% rule, meaning that if a kid is running 1 mile, then the next week, then they add 10% to that mileage, and to just really think about turning the dial very slowly and very gradually. A great website that I think a lot of people should take a look at, if you haven't ever seen it, is the one on the lower left there, Stop Sports Injuries. This is put out by the American Orthopedic Society of Sports Medicine, and it's really tailored to sports specific information, both like we've covered today in terms of potential injuries as well as injury prevention programs. Know that there have been some that have put out there. There are ACL prevention exercise programs. This is the FIFA 11 in the bottom right, which can be a good example of ways that individuals and teams can work hard to help their kids stay safe and healthy. Dr. Bellick talked about the recommended pitch counts. We recommend all athletes at all level of activities to perform a proper warm-up and cool down routine. Incorporating, as we talked about already, strength training and stretching and hydration. So keeping all of those in mind. Again, checking equipment and gear. If it's been gathering dust in the garage for a year, it may or may not fit anymore. Don't let the younger siblings always have hand-me-downs. Don't be afraid to invest in new shoes. Make sure the protective gear fits well. Check it before you get to practice. Invest in helmets, pads, shin guards, mouth guards. All of these do have an important purpose, again, to help keep kids safe. And then finally, last, I would just leave with a message that we hope that everyone keeps in mind, that we are wanting kids to be active because it's fun. And probably the most important message we all can give our own kids as they participate in sports is to be encouraging and to simply say, I love to watch you play. Make sure at the end of the next game to just tell your kid that simple statement. You don't need to dissect their play or analyze it. Be a good sports parent, let coaches coach and let parents cheer. Don't forget to say thank you to the referees that are out there helping them be active. And again, just keep the message that we're all here to have fun. So that concludes the presentation part of our webinar. We would be happy to address any questions that anyone may have. You are welcome to utilize the chat box to submit your questions. I'm seeing one specific question. I'm happy to have anybody answer this one. What type of stretches should a child 8 to 10 years age do prior to doing soccer after not playing since the pandemic started in order to avoid injury?
Well, I think that a comprehensive stretching program should involve warming up all the major muscle groups, and there's so many different types of stretches, and some that are very focused and some that are more complex stretches. But I think in an 8 to 10-year-old, I think that a general program where you're working on some toe touches, whether seated or standing, I think are really important. I think getting the core muscles warmed up by doing a trunk rotation is really helpful. I think it's important to get the shoulders moving, big shoulder circles. I think stretching out the calf muscles is very, very important. So that's kind of one foot in front of the other. There's a lot of different ways to do that. And I think that, generally just kind of getting the blood flowing by, having them do a little bit of running, have them doing, either some jumping jacks or, dare I say it, burpees. I think it helps get the blood going to those muscles too. Dr. Harnley, what are some of your favorite stretches, for that age group? Because high school, I would recommend a little bit more, but that age group, I think just getting the blood going is important.
Yeah, to be 100% honest with you, the pendulum keeps swinging. Every 5 to 10 years, people have arguments and discussions about whether static stretches or active warm-ups are more important. And I think just kind of engaging that whole body into those is really probably the most important way to do it. But as I said, it's more important to think big picture in terms of practices. So if you're signing your kid up and they're going to begin practices twice a week for 90 minutes on, I'm making this date up, June 1st, then they should begin preparation for that in advance. And whether that's just them running around and being outside themselves for an hour, jumping on the trampoline, just being active in advance is really just making a good way to make sure that their bodies are ready to tolerate that. I'm seeing a second question. Oh, go ahead.
I was just going to say, one thing I would add to that is that when your kids do start practicing, one thing that may be a surprise is that they may complain of soreness in the first couple of weeks after they begin, especially if there's an intense period of exercise with some sprinting, conditioning. There's this concept of delayed onset muscle soreness, and it's probably more relevant in our high school athletes. But 3 or 4 days after their first workout, suddenly they're going to be sore, and they'll stretch it out and they'll feel better. And they may complain about aches and pains that may be centered over their muscles, not over their joints. And that can be normal. And it can take them a few weeks physiologically to get used to that new load, and make sure that you don't confuse that with sprains or strains. It'll be a little dull aching in the muscle. It may feel good to stretch or rub the muscles. And if they respond to that kind of therapy, it's okay to give them a little bit of Advil or Motrin or Tylenol. Sometimes parents are worried they're going to mask some type of pain, but that's perfectly fine, to do that. But be aware that the first few times they work out, after it's been a while, that they can be pretty sore afterwards.
I have one other question. My son had a fracture during COVID on both wrists. What should we do about returning to activities?
I can take that one if you want. So I think a lot of it is going to be kind of based on your situation. So not every fracture is the same, so it would depend on the type of the fracture. So I think it's definitely important to make sure you work with whoever was treating the fracture as well. In general, there are mild fractures that we see and treat that can heal as quick as 3 to 4 weeks, but most fractures are probably closer to the 6 to 8 week range, and that's kind of healing time. And you have to remember that even after that, there's going to be some residual stiffness and weakness that you have to work your way through. So without going too much into specifics, I think you definitely have to kind of work with your practitioner to get quote unquote cleared. But in general, you basically want to return to activities when your risk of a refracture or re-injury has returned back to baseline. So it's tough to kind of quote an exact number, not knowing the exact fracture type.
Yeah, I think it's always unrealistic for families to expect that the day the cast comes off for kids to be able to rush back into everything. It's again, I'm repeating myself, but it's always important to kind of take things slowly and gradually. I'm not seeing any other specific questions in the question and answer area.
I was just going to make a quick point while we were waiting. If anybody else chimes in, is that you guys had touched a couple times on shoes, and I'm into running as well, and definitely just driving home the point that the shoes make all the difference. And there's a difference between going to a shoe, quote unquote, shoe store and going to a running store. So there's different brands of running stores that obviously we don't have any connection to, but there is a major difference between the type of running shoe that you get at those types of stores with different stability shoes, and then also with inserts and insoles for those. So if you do have a child who's interested in running or cross country or track, it's definitely worth the investment for getting those types of shoes.
And they should be replaced every 200 miles. So not just
there's actually another question in the chat box, just so it's not in the Q&A section, so it's just in a different spot.
Looks like Dr. Mcpartland said he'll address it right there.
Yeah. So the question was a general question about a child with knee pain that is a high schooler and plays softball, but also has a diagnosis of scoliosis. Generally, scoliosis, while it can throw off some of the general balance of your body, does not lead to pain in other areas. And knee pain is probably a biomechanical phenomenon related to softball, and there could be a whole number of things that can contribute to that. The first message said it was bilateral, that it was both knees. Generally, bilateral suggests that it's biomechanical, by nature, because you don't have many pathologies other than mechanics that cause pain on both sides simultaneously. And so that's a child who would probably benefit from a generalized strengthening program. You want to take a careful look at, how their, what their running looks like, what causes them to have pain. Unfortunately, anterior knee pain or pain under the kneecap can be a problem for teenage athletes. And sometimes it's one that you just, don't have a solution for that really, comes to the fore. We don't do a lot of surgery for that. We really try to avoid it, actually, because it probably doesn't help very much. we don't do injections. A lot of the treatment is really focusing on strength in the right areas. If it's a problem with overuse, then sometimes you have to look at how many hours you're doing it, or if you have a catcher, you want to, consider maybe, varying the positions a little bit. But that's probably something to talk directly to a physician about. But certainly a valuable question to ask.
I don't know if maybe I answered the question. I saw the question pop up about good shoes for running sports, but maybe I answered it. But if not the two that I was referring to that I'm aware of, maybe the other panelists know of others, is Roadrunner and Runner's High are two examples of running stores. And I don't think it's necessarily about the brand, as they just do a better job, I think, of working with you for your particular running sport, and then also for your particular foot and ankle. I think they do a nice job with matching you with the correct shoe and the correct level of shoe, not necessarily exactly what brand it is.
All right, well, that's great. Well, I think we're approaching the end of our time here today. So a big thank you to everybody who was able to join us. We hope we have been able to help address some potential concerns. And again, hope everyone stays well and stays safe and has fun in this upcoming year.
Excellent. Thank you.
Thanks, everybody.
Thank you.